हेलो ए मते ऑडियो की सूट नहीं की वीडियो कौन कर दी
Hello.
हाँ हेलो
Hi, good evening, sir. Dr. Jitender here.
हाँ या
Yes, sir. I think, hello, good evening, sir. Dr. Jitender here, sir. Dr. Daljit has joined, it seems. And Akhila,
Yes, sir.
can you promote Dr. Anant Mehrotra, Dr. Sandeep Mohindra, Dr. Alan Tripathi to the panelists? Because I can see they are in the attendees list, not in the panelists.
Yeah, sure, sir. Dr. Anant and
Anant Mehrotra, Dr.
Okay.
Sandeep Mohindra, and Dr. Alan Tripathi.
okay, sir. Okay. Done.
connected हाँ ठीक है चलो এইଥିରେ ଅଛି ତାର ଅଡିଓଟା ଏଇଠି ପଡା ଏଇଟା ବଢେଇଲେ ତ କିଛି ସୁବିଧା
Akhila, there is a query. People can't hear somehow. I don't know why. Dr. Alan Tripathi has posted that he cannot hear anything. Good evening, sir. Dr. Daljit, sir.
Hello,
No,
can you hear me?
Yeah, I can hear you.
You're
and I can
audible,
see your
sir.
slides.
You're
Okay,
audible.
thank you. Right.
Dr. Alan Tripathi, is it audible to you? Because you just mentioned that you cannot hear anything.
Yes, I'm just
You started.
connected. I
Good
can
evening,
hear you now.
everyone. On behalf of Dr. Anil, because he called me that he's busy somewhere, and he just assigned me to moderate the today's webinar. So I welcome you all on behalf of CVSI and Dr. Daljit, sir. I welcome all the panelists, Dr. Sandeep, Dr. Anant Mehrotra, and Dr. Pradipta Tripathi also joined, Dr. Alan Tripathi. And with the permission of the panelists, can we start the webinar?
Yes, yes.
5 minutes. Thank you so much, sir.
Please.
Sir, the slides are visible and we can start.
So I can start?
Yes, sir, please.
Yes. Good evening, everyone. First of all, my apologies because I was supposed to be last speaker, but then there is some urgent commitment because of which I have to leave a bit early. So please forgive me, those two people who were to speak before me. Appreciate CBSI efforts to continue with their academic activity and very well chosen topics time to time. So the allotted talk to me is endovascular treatment of arteriovenous malformation. So for this audience, I don't know how many people are still there listening to this. We have had experience of now arteriovenous malformation of sorry, someone said something.
I think Akhila, you can mute everyone except sir. Except the speaker, you can mute everyone.
Okay.
Yes, sir, please.
So I would be talking about endovascular treatment, and believe me, endovascular approach in the treatment of arteriovenous malformation has actually made us understand a lot of things about AV malformations, which during our residency or even during the excisions were not properly understood. Because it involves endovascularly catheter placement not only into the parent artery, which is feeding into the small arteries which are feeding, and a careful assessment of entire complex of arteriovenous malformation has led to a greater understanding about the concept what is arteriovenous malformation. And this knowledge is important for each one of us to understand, because whichever mode of treatment we believe is okay, I think understanding of arteriovenous malformation from endovascular approaches is paramount. It gives you much more greater clarity about the anatomy. So we all know the treatment options are surgery, endovascular radiotherapy, sometime observation alone, and maybe a combination. Now, facilities available in the treatment, cost, angioarchitecture are also important parameters in making the decision. Aim of the treatment currently being said is that prevention of bleeding, control of the scissors, improvement of the quality of life, and also somebody who is harboring arteriovenous malformation, even if it is silent, there is a lot of anxiety, depression, and element of venous hypertension, which these patients could be having because of angioarchitecture of AV malformation. Therefore, a proper understanding of each and every case in terms of angioarchitecture is a very paramount importance to be able to treat that. As far as embolizations are concerned, we have three types. De novo embolization for arteriovenous malformation as a therapeutic option. Then it can be pre-surgical or pre-microsurgical, which can decrease the vascularity. And it can also be applied for pre-radiosurgery methods of treatment to decrease the volume as well as the size with the help of endovascular embolizations. Now, it is important to understand what exactly is an AVM. It is a tangle of abnormal dilated arteries and veins, may lack capillary network in the nidus area, leading to a high flow into a low resistance shunt area. And there are high flow, moderate flow, and low flow of arteriovenous shuntings, which have been described in the literature, and actually they exist, and also helps us in making decisions how to treat them and understanding about that. Lesser known things are that there are evidence now that there can be sentinel hemorrhages, multiple sentinel hemorrhages in arteriovenous malformation, unlike an aneurysm sentinel bleed, which normally happens a few days before the actual bleed, and it could be as alarming as that. These sentinel bleeds in arteriovenous malformations are much lesser magnitudes, lesser intensity in terms of symptoms, and they can be picked with the MRI sequences at an area around the arteriovenous malformation. Also important to understand is that the concept now is changing, that around the nidus, there is an area of gliosis, scarring, and inflammation. Now, this is a new concept that beside gliosis and scar, there is an inflammatory pathway which exists all around the arteriovenous malformation, and that has resulted in choosing of some newer anti-inflammatory drugs or other drugs which can be of relevance in the treatment of arteriovenous malformation. Now, 95% cases are sporadic, 5% are congenital like hereditary hemorrhagic telangiectasia, and CMAVM, that is capillary malformation of arteriovenous malformation. Both these terms are catchy. Capillary malformation and telangiectasia, these are forms of arteriovenous malformation which exist under the category of AVMs, but unlike a classical arteriovenous malformation, they will not have a big artery which is feeding them or a big vein which is draining away the nidus. So these categories are congenital, and I'll make you understand a bit more. Now, another important thing to understand is it is a dynamic condition, arteriovenous malformation, meaning thereby there is a constant growth of nidus of arteriovenous malformation. And this growth or a disorder is now very well understood and is a cause of failure of treatment, whichever mode of treatment which may be adopted, surgical excisions, endovascular embolizations, or with the Manif or SRS. So that's an important, it's an ongoing dynamic phenomena. Many times when whichever method we treat, patients do come out with a recurrence or a regrowth of malformation. So though may consider it as a benign condition like malignant tumor, they do come back with the regrowth, and regrowth is very well understood. That's why it is known as a dynamic disorders. Now, 80% of arteriovenous malformations are generally silent, asymptomatic. Statistically, incidence is up to 2 per 100,000. 1 to 2% cases may present with stroke, much more common stroke in children, 25% of the brain hemorrhage in adult of less than 50, maybe because of arteriovenous malformation. Important is 20% of these patients may present with seizures, and which is a very high number. And mortality rate has been very variably reported from 12 to 66%, very high number and very low number. Now, brain hemorrhage in an unruptured arteriovenous malformation is 2%, as compared to 4% or 4.3% in a previously ruptured aneurysm. So incidence is less as compared to aneurysms. Now, this is an important slide for you to concentrate. AVM can be mono-compartment, it can be multi-compartment, and there may be areas of hidden compartment. Now, what does it mean? Now, we will understand mono-compartment means it is confined to the one area of the brain. Multi-compartment means it is multiple areas of the brain, and they may appear to be one in as far as mass is concerned in angiography. Hidden compartments are the multiple compartment in between. There are areas which are normal brain, and that's very important observation. And this hidden compartment is an area where a lot of activities of dysregulated angiogenesis is happening, and which can result in recurrence or regrowth of arteriovenous malformation from this hidden compartment, which was not showing up on angiography previously. And that is because there are angiogenic factors are being produced because of this dynamic pathways or dynamic phenomena. And some of these are vascular endothelial growth factor, angiotensin pathway, presence of hypoxia, metalloproteins, and deranged pericytes. All these mechanisms or the cascades of events have been reported in this hidden compartment, and that is available. Unfortunately, as a neurosurgeon, we are not focusing on this hidden compartment, and imaging is also not that evolved, which can suggest possibly within that area is an hidden compartment, which may be cause of failures. So recurrence, as I said, is because of dysregulation of angiogenesis, regrowth, because of the phenomena which I have explained. In addition, now there is a genetic basis is also coming up in the literature, like of tumors, BRAF gene mutation, KRAS gene mutation, and many more genetic bases are now being suggested in the genesis of arteriovenous malformation. So sometimes people may wonder, or sometimes even we need to think, is it kind of a tumor or a malformation alone? Isn't it a dysregulated growth of a tissue? Tissue in this case is the arteriovenous malformation or the blood vessel. But why not to call them categorized into AVM also if they behave like as a tumor? Now, please focus for those who are not much familiar with the arteriovenous malformation. Yeah, this is an artery which you all see, and other side is vein. Do you see my pointer? Hello?
Yes, yes, sir. We can.
Yeah. So in an arteriovenous malformation, there is an arteriole which is network is forming, then there is a venule and it is draining. And in an AVM, it all system gets dilated, and then there is an artery feeding this. Now, this is a classical example of a mono-compartment arteriovenous malformation. Now, imagine if I have one compartment, second compartment, third compartment, four. All of these pictures are suggestive of individual arteriovenous malformation. They become polycompartment or multi-compartment arteriovenous malformation, may be located in one part of the brain or multiple compartment of the brain, and may show as one single mass in a DSA or angiographic film. So that's very important. And we realize this thing when we do endovascular embolizations that whether it is a mono-compartment or multi-compartment. So we will understand as we progress further. Now, according to physiology also, as you see this image, we can have an arteriovenous malformation, which could be a very high flow. If you say arteries are being depicted as a red color, even this nidus has been shown as a red color. And if you see this vein has been shown red, these are arterialized vein where the pressure head is getting transmitted too much into the venous side. So that's an important observation. And during surgery, many times have difficulty in differentiating from artery from a vein or arterialized vein, particularly when they are more superficially located. Or we may have a situation like this, that the pressure head is not very much on the nidus. They may appear to be blue. There are multiple draining venules, and they may not differentiate. There is a one draining vein here. We have a multiple draining vein here, which have relevance in terms of degree of rupture and the recurrence and the other risk involved. Whereas sometimes we may have number of arteries, and these all venous may become a large sac, like a venous sac, heading into the draining edge. So there are a number of permutation and combinations which can happen in a angioarchitecture of an arteriovenous malformation. Now, if you see this, now we have multiple feeder arteries which are supplying a nidus, and there is a one draining vein. Also important to know is the last parameter. Beside having an artery, we may have very pile kind of a feeder, small vessels, which can also be or maybe supplying to this nidus. And for during selective embolizations, we are very lucky if we have a feeder like this. But these small feeders, like very small collateral, which are coming from the pile network, are difficult to cannulate and difficult to embolize also. And if we try to push our microcatheter into small these vessels, we may be able to push some contrast or some embolic material into this, but often they occlude these parent feeding pile vessel or maybe leading into the spasm. And these are more relevant when these perforators are coming out from thalamostriate or thalamoperforator or some perforator from the brain stem. So these become a difficult situation for the endovascular guy to treat them. Whereas if my current understanding is if we have a situation where there are a number of small perforator which is smalling, which are supplying the nidus, unlike this may they would be better suited for either surgical excision or with SRS. Whereas if you have a very good feeder, okay, which can be cannulated and embolized with a good ideal case for embolization. So then we have another compact and loose arteriovenous malformation. Compact is all network is in one side, and loose will have scattered areas. This loose may be having a multiple compartment at times, or maybe having a poly compartment, or maybe having a hidden areas between this arteriovenous malformation, which may later on. So after having understood this much about the basis of angioarchitect, let us proceed something about what is microarteriovenous malformation. Now, microAVMs are usually described as 0.5 to 1 centimeter. They are deep located, generally supplied by insignificant, inconspicuous feeding artery, which we find it difficult. Pile network suddenly fills up arteriovenous malformation, and we cannot identify a definite feeding artery in these cases, and may have a single or multiple draining vein. These are microarteriovenous malformation. Now, very important aspect comes is the risk of bleeding in an arteriovenous malformation. Uh, all of us as a neurosurgeon must have seen cases incidentally detected arteriovenous malformation, and there is a pertinent question which arises: what is the risk of my AVM rupture? So the literature says if there is a previous history of a bleed, there is higher chances of bleeding, presence of hypertension, associated aneurysms, deep location, impaired venous drainage or the venous stresses, because if the venous pressure head is not getting lower because of the shunting, it is chances the venous side will bleed. There are now mediators being discovered that presence of interleukin 6, 17A, ILB1, tumor necrotic factors, alpha, notch pathway, all these, presence of these pathway are not only getting implicated in the genesis of arteriovenous malformation, but also higher risk of rupture. Pregnancy is also being told as a higher risk for the risk factor for the bleeding. In addition, okay, let me go on to this. They may present with hemorrhages, subdural hematoma, epilepsy. Now, why epilepsy occurs? Steel, glasses, scarring, and inflammation, which I have already said in the genesis of epilepsy. It can present with neurological deficit, and I think all of you know how all presentations can be important. Now, we have had a couple of cases where the patient had blindness because of arteriovenous malformation, primarily because of steel phenomena, which they improved following treatment. Also, some kind of a dysphasia and aphasia. Now, next important thing to understand in arteriovenous malformation is various grading system and scoring system. I will not go into the details of that. Most of us are available. Spatula Martin, the grading system, Now, but what is important is that radiosurgery have a different steering system, endovascular guy have a different steering system, and surgeons have a different grading system available. Now, currently for endovascular guy, I think this is known as endovascular EMBO score system. I found this is more useful than conventional Spencer-Martin or modified Spencer-Martin and other grading system, and I'll try to explain. All these scale system have been given to predict the success rate of a procedure of like endovascular embolization, and also higher the risk of recurrence or maybe under treatment because of that. So one may adopt various scoring system, what is one familiar with, but then let us see what are conventional scoring system which we talk about. Now, if we talk about scoring system for the endovascular, we go with the size of the nidus, like 3 centimeter, 3 to 6 and more than 6 centimeter, we have a score. Number of arteries feeding 1 to 3, 4 to 6 and more than 6. Now, see, more than 6 arteries is possible to be feeding an arteriovenous malformation. And that's very important for understanding. It's not just 1, 2 or 3, 6 to 10 arteries may be feeding. And that's a careful assessment when we do selective angiography, when we find out, oh my God, there are multiple arteries which are feeding the aneurysms, and there's not one single artery. So more the artery, bad it is. Then similarly, venous drainage can be 1 to 3, 4 to 6, more than 6. More are the number of draining vein, lesser are the chances of bleeding, because the pressure head gets transmitted into the veins, various region, and they drain away. They're likely to be low flow also. And then the venous head pressure or venous hypertension is less, hence there are less chances of recurrence. Now, eloquence, you all know eloquence, but angiographic eloquence is also being said that within 2 centimeter of the feeding artery is a higher risk of rupture. Like for example, if a IVM is being fed within first 2 centimeter of MCA, there are higher chance of rupture. More peripheral it is located, obviously lesser will be the pressure head over there, and there will be more toward the surface at times, and easier will be the outcome of those things. Malformations. Various trials, Aruba trial has come, which was abolished in time, Scottish trial, currently we are having what is known as Nassau trial, new assessment of cerebroarteriovenous malformation, yet unruptured study. It has shown that after the first 5-year follow-up, relatively better outcome in the treated group than conservative group. This is absolutely opposite to Aruba, which found that a conservative treatment is superior to the intervention group, both either endovascular or surgical in terms of stroke, morbidity, and mortality. Now, very important thing is the type of the venous drainage, antegrade, retrograde, upstream, going into the venous. Normally, we focus on the dural AV fistula, but even in arteriovenous malformation, a careful assessment of the venous outflow. And now there are TCD findings which say the flow velocity is also a risk for the rupture of arteriovenous malformation. These are upcoming tool in predicting the increase in the chances of rupture of aneurysm. So studies suggest that TCD-based studies of less than 90 centimeter is a higher risk of bleed. And I think venous drainage, if my time will not allow me to talk much about, but I think I made my point that where is the vein draining? If the vein is draining into the direction in which it is supposed to be going, that is antegrade. If it is filling from one to another vein where it is not normally to be going inside, that becomes a retrograde filling. So both combinations of various types have been described in angiographic output, angiographic analysis of arteriovenous malformation, and therefore a careful assessment of the venous flow also makes an important parameter in assessing beside the artery, veins, nidus, and flow velocity. So newer and newer parameters are getting added up every day in the arteriovenous malformation in order to understand its pathophysiology, maybe a better mode of treatment, at least for endovascular side, and also predicting the outcome in terms of both. Now, for example, if I show you this video, Watch it out. It has many things in it. Now, this is a aneurysm here. You saw there is a vein, a large arteriovenous malformation. There is a venous sac. In one patient, everything exists. I'll play again. Let me show you here. Now, I have an aneurysm. It is just proximal to the PCA artery. And sorry, not PCA, it is PCOM. And aneurysm is located much proximal to the arteriovenous malformation. As we go further, now what this? There is a vein. Now vein, there is a large vein which is chunked there. It is going downward. There is a large sac which has formed and then it is draining downward. Now watch out. Then next, now you see the vein is filling from this. Some of the vein flow was going upward also. You must have noticed that. So rather than all going down, there was a retrograde flow in some of the veins, which is a part of the arteriovenous malformation, which is draining over here into the transverse sinus. And this is now watch out once again. So, you know, a very careful uh, assessment of angioarchitect, it becomes very important in making decisions both in artery as well as the venous phase. So again, coming into the where the veins are draining into various directions becomes a very important parameter for us, not only in terms of deciding what types of treatment we are going to offer. Sometimes it also helps whether we go arterial route or we go venous route or a combination of a route in order to be able to obliterate this uh, malformations. So there are other classifications available like Pradipta classification, which talks about the venous drainage and all, and also grade 1, 2, 3, 4 increases the chances of hemorrhage. Now route I have already said, we have transarterial route, transvenous route. Transvenous we prefer when it is difficult artery access, generally which is deep seated and we have a large dilated veins. A combination can also be taken. A word about catheters for arteriovenous malformation. These catheters are usually single distal marker as compared to aneurysm, which has two marker. They are longer in length because sometimes the MCA territory, arteriovenous malformation, may be very, very long, and the arteries which are feeding are long, tortuous. They take extra course, and usually sometimes conventional coiling catheter may fall short. And coiling catheters are a little stiffer as compared to the arteriovenous malformation microcatheter because the distal are hydrophilic in nature. They tend to flow along the route of the feeding artery without pushing them. That's a very big important advantage of these catheter. And sometimes this catheter has to be compatible with the embolic agent, which is being used in the treatment. Now, material which are used, initially we relied upon solid particles significantly, gel foam, PVA particle, detachable microcatheter tips, coils, all these have been used in the treatment of arteriovenous malformation, and I have personally used all of them. Detachable microcatheter tips came much later, but then initially when we found that we were treating arteriovenous malformation, the tip used to get stuck with the nidus and then it would break when we were taking out the microcatheters. Subsequently, the designs came up that why not to have a detachable microcatheter, even if it gets stuck, proximal portion of this can detach and whatever catheter is left out is not going to harm, like a detached VP shunt, leftover shunt in the ventricular cavity. Liquid materials are far, far more important. N-butyl cyanocrylate, onyx, squid, fill, a number of them are available in the market now. My personal take is the one which you can embolize better is your on-child. I have a maximum experience of NDCA now because it was easily available to us. And although onyx and squid are supposed to be having better penetrating power and filling into the small arterioles, into that. But then it is all individual experience what you can do. Assisted techniques are also available like balloon, double lumen catheter, pressure cooker techniques. There's some technical aspect which is beyond for this webinar to discuss. And so much so, adenosine has been tried to decrease the flow during the procedure so that the material, embolic material does not wash away easily and can stay at the site where one wants to embolize. Now this picture is illustrating a transarterial route and sometimes we put a balloon to occlude the artery which is feeding the nidus, and simultaneously one can go a transvenous route and embolize the material over there, which will fill retrograde from this to this place. When there is no flow coming from the arterial side, it is likely that it will fill into the venous side. Of course, there is always a risk of material going into the venous side during embolization. Now, there are two types of material described also, acute embolization and curative embolization. Most of us do curative embolizations, meaning by the patient has come with the diagnosis, has rupture sometime, it is not an emergency, so we plan it is and then go for acute embolization has been described in the literature when there is a bleeding with the bleeding, leaking arteriovenous malformation, or when you feel there is a high risk of bleeding because of the various factors which I just narrated. There can be more than one factor present in a single patient, and they may there may add on to the higher risk of arteriovenous malformation rupture. Curative embolization, unfortunately, is very good for specific Martin 1 and 2 with 50 to 90% cure rate with 3 to 6% mortality. Now, sadly, for grade 3 and 4, the results are still not very good. And most of you would agree that Spetzel Martin 1 and 2 are equally good for the best result for surgical excision as well as for SRS. So there is a competition between these three modes of treatment to choose which would be more suitable. So my understanding is one has to sit down, watch the angiographic film very carefully, look for the arterial, look for the venous side, look for the risk of bleeding. Please remember, SRS does not give instant cure. It takes its own time during which there is a risk of rupture always as well as a stroke. Same is true with the surgical excision. There is a higher risk of intra-procedure bleeding, hypoxia, normal perfusion pressure breakthrough, those risks. So one has to really carefully weigh what is going to suit your patient and your personal experience vis-a-vis location of arteriovenous malformation in the various areas. This part I have already, I think, covered up. Now, risk I have covered, location, draining weight, pregnancy, interventions, eloquence, all these I think I have covered up. Now, a systematic review which has been published recently, a number of articles have been shared, and let's see what is the result. I think somebody else was talking about it. Now it says endovascular treatment with a follow-up of 6 to 33 minutes, the best rate is 20 to 90% obliteration rate, and mortality and morbidity is significantly low, 4% to 0%. 0% mortality has been reported, morbidity 2 to 14%. I mean, our morbidity and morbidity is approximately 20% of mine. Mortality is almost in the same range, approximately 4 to 5% in our center. Now, one word about the presence of aneurysms within the arteriovenous malformation, and I said it can be proximal, it can be distal, it can be on the arterial side, it can be on the venous side, it can be not related to the arteriovenous malformation at all coexisting. So the hypothesis that aneurysms in an arteriovenous malformation is flow related or because of the hemodynamic phenomena is not always correct. One will have to carefully see where is the location. Intranidal aneurysms may be because of the hemodynamic changes. Just proximal to the nidus or maybe just distal to the nidus may be hemodynamic changes or because of alteration of perinidal hemodynamic. But then very proximally located or located in an artery away from the nidus. For example, if it is an aneurysm which is located in mid-cerebral artery and AVM is being fed with the arterial from anterior cerebral artery, there's no correlation. There's not flow-related arteriovenous malformation. So those things need to be assessed while taking up the selection of these cases. There is now tissue perfusion, angiographic malformation, like perfusion scan, diffusion scan, like a stroke, is also being evaluated in making the decisions while treating the patient with arteriovenous malformation. How much ischemia is or penumbra exists in and around the arteriovenous malformation, and the understanding is somewhat similar to that of a stroke. Risk factor, I think I've already covered. Follow-up of like if I have embolization area greater than 50% versus less than 50%, greater than 50% has a better outcome 5-year follow-up than recurrence rate if it is less than 50%. AVM diameter more than 3 centimeter has the poor long-term follow-up. Now, some of the images, now you can see this is an AVM and look at this vein on the right side. Now, look at the venous structure. This was an nidus, one vein, second vein, third vein, fourth vein. I mean, we thought there's a one vein, but then when you screen those images film by film, then you want to see, oh my God, how many veins are there? And this is following embolizations, a good case in terms of result was concerned. Whereas look at this MCA aneurysm, I do not find a very significant feeding artery, although there was a suggested this inferior trunk is going into that way. We went into that emboli, we found there is a tuft of vascular malformation, there is a draining vein overhead, embolized. But then there is some residual filling is also happening. And people can appreciate this filling of residual is the file network which is feeding the arteriovenous malformation. Now, if I see the first image, it was existing here. I do not have an artery which can be easily cannulated. So we left it and then kept it in follow-up. Yet another case, MCA arteriovenous malformation post-embolization. If you see very carefully, we have done a good job. But now when I see with a greater knowledge, it's an old case. And then you see, no, there is something still persisting. So this is maybe a hidden zone or maybe a polycompartment which started showing up after embolization. And its realization to us has come late once we have a greater understanding and the knowledge about the posterior circulation looks pretty nice. It looked to me I'll not be able to embolize this case, but when I took my micro catheter, it shows me a good network and see it has shown a good angiographic result. I'm repeating the word angiographic result. Now, we may have a dual supply, like the same case, anterior cerebral and as well as the PCA. Now, two arteries. One may do it in the same sitting, or one may have to take a staging from 1 to second, depending upon how much time, how much contrast material, how much radiation has been given while doing the procedure at one. We may be lucky to do it in one go, and we may struggle to find a catheter to reach into target, etc. This is how the cast looks after the embolization in any case. Now, and yet another case, HCA being fed. Now, it looks like one area here, another area here, third areas here. So see, it appears as if this patient has multi-compartment arteriovenous malformation, which are being fed with the various different branches of anterior cerebral artery, maybe draining into one venous drainage, or maybe they're finding various different venues to go into that. And as a result, see what we found. We have actually landed up into a small, look at this artery going here. This is selective shoot artery going here. So that allows us understand how AVM looks like, how AVM's anatomy is. Now, again, cast material in this area, some residual, which will happen in this condition. Now, one such case, pregnancy, she came with the bleed, she had a small AVM, she decided no treatment to be done, and good, nothing happened to her. Now, this is PCA. This is the same patient, that pregnant female. Now, we had advised her that also she decided, issue was that she had a pregnancy, whether to continue with the pregnancy or not. She was approximately 8 months, if I am not wrong. Yeah. And then, no, not 8 months, sorry. It was around 8 weeks. And ultrasound detected that the baby is not alive. They went to a center where she was advised for termination of pregnancy. At that center, gynecologist said, we will not touch the case unless you get your arteriovenous malformation treated out. Okay, now they went to another center. Similar answer. When they came to us, we said, why not? I mean, we will do this, but then there's nothing you can go for termination of pregnancy, and we will do almost next time itself. Anyway, we repeated an ultrasound in our center, and we found the baby was viable. So ultrasound variation in terms of detection of viability, different happened from one place to another place. And of course, in between, from one institution to another institution, there was a window period of approximately a week to 10 days, in which time ultrasound could have picked up fetal heart sound much better than during the early phases. Anyway, this patient had already started anti-epileptic drugs, some drugs, so she took a decision, I will not do. My gynecologist said, no, we will not touch unless you first treat. So we were in a dilemma. Patient decided, I do not want any treatment. They got it terminated, and she is under follow-up. We'll see how she behaves. So such situations may happen. Now, this is the first case which I showed you. Now, why I'm trying to show you, this is some lessons for us. Watch it out again. Now, this was that case I showed you, partially embolized. And if I can stop it, no, see. At the end of my procedure, we were not able, we coiled this aneurysm, which was much proximal located. We embolized this, and look at the follow-up of this after about a week time. Everything has gone. And watch out this again. It's not the same setting. We were still having large venous sake, which is coming up, and follow-up scan, which is shown, this has disappeared. We thought maybe it is some good luck for her. Let's repeat after about, I think this is about 1.5 months, if I'm not wrong. Okay, my aneurysm is also not visible. My venous side is also pretty healthy. I have a deep venous system, no more venous lake seen as it was seen in the immediate post-embolization procedure. So we also learned that, of course, it is not necessary. You give time for staging of the treatment, and maybe nature helps you by the reduction of the hemodynamic flow, and you may get a natural treatment in some of these cases than trying to do everything. Complications, yes, catheter blockage, catheter stuck, catheter rupture, hardware complication, procedure related. There can be AVM hemodynamic related. People have reported stroke, premature artery blockage, rupture, and others, anaphylaxis, volume overload, fluid, everything can happen. One of our case, intra-procedure rupture, hematoma formation, some of them landed up delayed with an abscess formation, micro abscesses. The sterility of embolic agent is now becoming an important. We've had a very good a series of cases over the last 20 years. At least I must have at least 10 cases where delayed micro abscesses have been reported in the areas of embolizations successfully done. And absolutely this has to be related to the sterility issues of the liquid embolic material, or I don't know whether it's a contrast or the material of IV fluids nature, something, or maybe the catheter which we were used having some kind of flow. But these are delayed abscesses which can come. In 1 or 2 cases, we had to open up, excise the abscess. We lost one case at least because of the large one hemispherical abscesses landing into diffuse cerebritis and all. For me, situation like this, large hemispherical arteriovenous malformation, I still do not know how to treat them. Okay, there is no, will I find no definite reader, no rich pile network, and they still, I feel, is difficult for, like if you see, we have a tuft of capillary telangiectasis, like, or a puff of smoke kind of an appearance, for which there is not even identifiable one single artery. There's a small number of small pile-based vascular malformations which are feeding, and may not be an ideal case for endovascular embolization. So to conclude, endovascular treatment has made a big impact in the treatment of arteriovenous malformation. Angioarchitecture study is paramount. There is no perfect embolization material so far. And of course, selection of an ideal case is the prerequisite, and we require more and more neurosurgeons training to be able to do DSA, identify various aspects of arteriovenous malformation, and take decision what will be best suitable for the patient. I think this way would close my talk. Thank you so much. Am I audible?
Yeah, you are audible.
Yeah, thank you.
Very nice presentation.
Thank you.
Dr. Tripathi is there. He has something to say. Dr. Sandeep. Dr. Mehrotra, if something
I
to
think
comment.
really enjoyed Daljit's talk, and he is one of the hybrid neurosurgeons that, with a lot of experience. Daljit, what is
Yes.
your experience on transvenous embolization of these AVMs? I know that, fistulas like CCF, etc., they're good for both arterial and venous. Do you really think that transvenous embolizations or, of this kind of AVMs is successful, or a lot of people talk about it?
Yeah, it is very important. Artery, if I do not have a good feeding artery, if I cannot identify a good feeding artery and I have to do something, and if I can reach to that vein which is draining, not into the sinus, reaching the sinuses, whether it is transverse sinus or sagittal sinus, is very easy from the transvenous route, not difficulty. After that, hooking the catheter into the draining vein on reaching close to the nidus. It is something important. But then believe me, it's very, very good. It helps us tremendously for those cases where it is not easy to access. My preference till today is an arterial route. Okay, because the venous route have a risk of pushing the contrast material, it will come back toward the venous side. Whereas the arterial side, I'll inject close to the nidus. First, it will go into the nidus, then only it will go flow away to the venous side. Whereas from the venous side, unless I occlude somehow the proximal artery, okay, it will all get washed away into the venous side. So that is what is important. But then it is a very important to analyze whether I can reach that nidus site. Whereas dural AV fistula transvenous route is excellent. They are in relation to the transverse sinus, superior sinus. That is what dural AV fistulas are there. And they work pretty good because you can take your embolic material or coils to occlude, depending upon whether you want to occlude or you want to open the stenotic area in dural AV fistula. That approach is largely dependent upon the transvenous.
Thank
But
you.
it's yes, important. We as a
And
neurosurgeon.
you also, sorry, you also said that you are, of course, with experience of NVCA, you prefer that to Onyx, because a lot of people, depends.
Dr. Tripathi, honestly, our experience of Onyx is largely based upon it is much more cheaper and easily available. Now, in our hospital, we are dependent on the supply from the government. We do not have the sanction for either fill, Onyx, and material. So these are very easily available. And when I started, only material available was NBCA.
NBCA.
So
yeah.
my start happened with NBCA. We continued with NBCA, and I think I must have embolized more than 200 or 300 arteriovenous malformation of various types. And then we
Exactly.
found I can regulate them. All I have to do is decide what concentration to be made, depending upon the flow nature, how fast it is flowing, how slow it is flowing. One can use it, and then
And the
I had
dilution factor is also very sort of important, isn't
very
it?
important. See, with the NVCA, you can control your dilution. Whereas for Onyx, Fill and all, they are coming up in a fixed dilution pattern.
Absolutely, yeah.
So that's one, you have to add on solvent. So I find this, although there are much more literature available with Onyx now, and then because ease of injection is easy, it has a greater filling capacity than the Onyx. But then that is how. Otherwise, there are people, some of the very senior people who are into this work, they said we have never used Onyx and Fill, we still use the NVCA. We found it because possibly they have got accustomed to it, used to it.
Thank you very much. You have, just last question, do you have radiologists doing the same in the team, or only you do it?
No radiologists.
Okay.
It's exclusively all neurosurgical.
Thank you so much.
Yeah. Sandeep was saying something. Sandeep, you said something?
Yes, sir.
Yeah.
Sir, good evening. One question related to this, that what is the failure rate with the endovascular in your setup? Like you have done around more than 200 to 300 cases. What is the failure rate means? Can recanalization and redo embolization for the cases, and which select cases will require redo and redo? And what is your take on regarding endovascular management for some particular cases in the presence of radiosurgical treatment available across the country these days?
Yeah. So the first thing is failure rate. Okay. Now failure rate is to be defined as I'd say if it is less than 50% obliteration
Okay.
in the first row, I consider it as failure. Although literature says grade 3 and grade 4, the success is only up to 50%. There are grading system. Grade 1, 100%. Grade 2, 75%. Grade 3, 50%. And grade 4, see up to 25%. This is obliteration rate. Okay.
Right.
Now, when we talk in terms of obliteration of an AV malformation, I will consider the success rate of 100% obliteration in the first go is only 30 to 40%. Okay. I will
Okay.
rely upon the second stage of embolization in another 20 to 25% of the patient. Come back, do it again, or in the same admission, maybe day 2, day 3, day 4, because this is depending upon OT availability. Large AVM malformation, more than 6 centimeter, 5 centimeter, it is more than 70-75% failure rate in terms of obliteration. Now let's come to the second part, regrowth, or patient has come back with a recurrence or for this. All cases where there is no 100% obliteration will come back with a regrowth over a period of time. Okay. The areas which we have embolized also tend to start showing, oh my God, there is something new which has started forming in those areas. And that's where I said arteriovenous malformation is just not a tuft of a blood vessel. There is a new angiogenesis which is developing in these patients. Even if I have done 100% successful, long-term follow-up would show some kind of a recurrence. Unfortunately, in our setup, and which may be true largely many more setup across India, the follow-ups are bad. Once the patient has been treated, there is no bleeding, there is not rupture, patient has not had any seizure. We do not encourage also to come back and do the angiogram either with a CT, MRI, and do DSA to be able to see. So honestly, will not be there. So focus largely becomes that time treatment once you have done a procedure, how the patient gone back with a successful embolization, obliteration, maybe some, do have a number of cases which will come back. And I think now we are confident in saying the failure is largely for those whom we did not embolize properly, whom we did not actually understood right from the beginning. Now our failure rates are less because now we minutely see, okay, ye reh gaya, wo reh gaya. Now for my residual cases, I said, okay, go for SRS. Okay, I will not be able to embolize this zone because I do not find a good artery which is there. So I'll say, okay, go for SRS. And then we gave options for SRS right from the beginning. If patient says, okay, humne karana hai to jao. Often I find they're large. We'll go for a staged embolizations, one sitting, second sitting. Surgery by and large is getting much less and less opted by these patients also, like with aneurysm.
Okay, so there are two questions. One from Deepak Khatri.
Yeah.
He has asked, what concentration of NBCA do you use? And
Okay.
what is your workflow of deciding between targeted embolization versus curative embolization?
Okay. So the the first question was concentration.
Yeah.
See, normally I will go anything from 30 to 50%. Okay. That is what we use. Like, for example, there is a syringe of 1 cc insulin syringe. I'll take 0.1 cc of NBCA and maybe 0.3 cc of lipidol, which we use. So it becomes 1 in 4 totally. So 30 to 40%. Now, decision is made upon the angio architecture of the flow. If it is a high flow, it means it is likely to wash away versus a low flow, which is likely to be stable. A one which is likely to wash away, I'll have to take something which I do not allow it to wash away. Okay, so the concentration will be regarding that. My target is to, depending upon how much angiographically I look. If I want to go for a curative embolization, it will be only for the size less than 1 to 1.5 or 2 centimeter, 3 centimeter. And if there are 1 or 2 feeding artery, I'll go. Let's go for a curative embolization. If it is larger, I know multiple arteries are there. We'll go stage it, go some area embolized today, maybe second sitting, third sitting. So all will depend upon what I get to see during the procedure. Individualize. It cannot be. Also, simultaneously, one will have to look for, like for example, the case I showed you. It was not a curative embolization. We had an aneurysm much more proximally. I partially embolized because there was a large vein. And by that time, I realized if my veins contrast goes into that venous sac, which was visible, it stays there. Maybe there is a risk of a venous bleed also. Back pressure changes, still draining. So I decided leave it. And nature took care of it. So number of things we will decide. But then given an option, curative, yes, everybody wants to go for a curative right from the beginning. But then one has to have an honorable retrieve back also in situation rather than unnecessarily trying to take a radiological. I'm using angiographic cure versus actual cure are two different things. You may have angiographic disappearance of lesion versus actually disappear. So there are two different things.
Okay, thank you, sir. I think we'll move on.
Thank you. I'll seek your permission to leave because I have to go somewhere. Thank you very much. And I hope rest of the talks are more useful. Thank you, dear.
Thank you.
Thank you, sir.
Thank you, Daljit.
Thank you.
Now,
Thank you, Daljit, sir. I think Dr. Jitender has to give
Dr.
some
Daljit,
personal-
are you there? Somebody asked one more question. Do you also use glue if doing transvenous?
Sorry?
Do you also use glue if doing transvenous?
I mean, can you qualify which glue is he wants to say?
And that's he has not
Biological
mentioned.
glue?
Maybe he's talking about this CLN.
Biological glue, I think
Yeah,
so.
maybe.
See, I have not used biological glue as yet. Okay. But I fully agree. If you understand the concept of arteriovenous malformation, biological glue should be useful also. I have no personal experience, although because maybe it is more biological. Maybe it will be resulting in a better result. You know, if you read NBCA, while it is written not to be used for intravascular compartment, very clearly written, and we all are using it. Okay, so off-shelf indication.
Okay. Okay.
Thank you.
Thank you.
Sir, Anand this side.
Anant, you
sir-
have something?
Yes, sir, yes, sir. So
Yeah, please.
actually, Dr. Jitender had to go for some family commitments. So I shall be moderating the session from now.
Yeah.
Sir, one question for Dr. Daljit, sir. Sir, if you use NBCA as a pre-surgical tool for embolization, for how long can you wait until you can take the patient for surgery?
Okay. See, normally it is said within 72 hours in a partially treated arteriovenous malformation, there will be evidence of revascularization, 72 hours. Okay. Now we have extensive work in brain tumor embolization with NBCA. And our role is for skull-based tumor, we would do within 72 hours. Otherwise, it doesn't serve. There is a chances of recanalizations of the embolized material and may form the or a regrowth. But then, having said that theoretical aspect, surgically, if I said if I embolized here, preferably within 72 hours to 1 week time, one should go ahead and operate. Because surgery is not just governed by a technique. It is so many things which is going to decide for patients. Like for example, if a patient who has a high risk, surgical high risk, whom I have done partial embolization, okay, is to be put on second anesthesia within say high risk patient within say 2 to 3 days. My anesthetic say इतनी क्या जल्दी है भाई तुम्हारे को कोई life saving थोड़ी ना ठीक है wait कर लो. Give him a 1 week's time for that the brain to show you some kind of adaptability for this to learn. But then literature says 72 hours because there is a chances of recruitment of the new vessels from the adjoining area. It is more so when it is partially embolized. I don't know how is your SRS team follows what principle there for stereotaxy, but I don't know surgically it is like. We prefer
So why
to
I was
do
asking
within.
this is because it is said that one of the advantage of ONS is that ONS can actually provide you slightly longer waiting period.
Yes,
As compared
very
to
true.
the MBC.
Very
So,
true. Absolutely. Absolutely.
you.
But then how long? I mean, I think they also say about 2 weeks.
Yes, sir. So they said you can wait till 15 days to even 1 month. You can
Okay,
wait
2 weeks to
to
4
on
weeks.
it.
That's correct. I agree with you that. Yes.
Thank you, sir. So now, after having an excellent
Thank
talk
you.
on endovascular management, we would now move on to the second important method of treatment for avians, and that shall be taken up by Dr. Pradipta Tripathy, and he shall be discussing about the basic steps of avian surgery. Sir,
Yeah.
over to you now, please.
Yes. I'm just trying to share my. Are you able to see my slides?
Yes, sir. It is visible now, sir. It is
Okay.
visible.
Okay. So I will be talking briefly about basic steps, basically, as we learn from our teachers. So as Dr. Daljit already introduced, given introduction, intracranial avians incidence wise, it is 1.4 to 4.3%. Treatment should be considered for avians irrespective of grade, that a blade or uncontrolled
Sir, your
seizure.
slide is not moving forward. Sorry, sir. Your slide is not moving forward.
Is
No, sir. It
moving
is
up?
still, no, sir. It is still the first slide.
Okay, and that okay. Let me see. You are now seeing
sir.
my slide.
Yes, sir. We are able to see your slide. So can you just move on to the next slide? Yes, sir. Now it is moving, sir. Yeah, now it is moving. Please go ahead, sir.
So intracranial avians incidence ranges between 1.4 to 4.3%. As we all know, treatment should be considered for avians irrespective of grade, that are blade or uncontrolled seizure. Ideally, should think of treating a patient who has blade or uncontrolled seizure. Then AVM treatment should be always tried to be a curative one with low morbidity and mortality. Best treatment option for particular AVM, it should be discussed thoroughly by multidisciplinary team. And treating doctors should have a thorough knowledge of intracranial vascular anatomy, all systems, sulcus, circumvallations, and interpreting cerebral angiogram. That is very important. Whoever is planning for a AVM surgery. Now we all know it broadly, it has been classified superficial and deep, and in use no superficial, it can be cortical, subcortical. Now going to this angiogram for if there is youngsters there in this webinar, how the AVM actually is seen, it's everybody knows there is a feeding artery, and you can know the feeding arteries here going. This is AVM and this is the draining part. This is another hospital surface AVM, and this is the corresponding angiogram. This is another picture of deep separated AVM, and you see the feeding arteries, draining veins, multiple. And before planning for AVM surgery, as Dr. Daljit said, there are multiple grading systems, but for surgery, we always prefer to take into account the Spezzo-Martin grading. And the three things have been taken into account, that is size, eloquence, and pattern of venous drainage. And they have been graded into 3. And for surgeons, beauty, it is always 1, 2, and 3 is the best for surgical modalities. And it's a picture taken from the SMIDEX, and you all know how this grading can be actually conceptualized because of this 3 combination size, venous drainage, and eloquence. So in grade 1, you can have 1 variety, and grade 2, you can have 3 variety, 3 types of AVM, but they are all grade. It can be vary from the local eloquence to non-eloquent, deep to superficial, or size is 3 or more than 3. Similarly, grade 3 can be 4 types, and grade 4 is for 3 types, and grade 5 is 2 types, 1 type. Now, what are the treatment options we have? We have, as mentioned by Dr. Daljit sir, you can only observe if the patient is not clinically and it is incidentally finding that there is AVM there. And surgery, yes, the option of grade 1, 2, and 3A can go for surgery. And if it is 3B and 4, you can pre-embolize and then wait for a week. And depending upon the material used for embolization, you can wait for a month and do for surgery. And you can go directly, as he has demonstrated few cases of endovascular intervention, directly curative, or you can go for radiosurgery. At times, you can go for combination therapy like embolization, surgery, then you can go for radiosurgery, like that. So what is my talk is not basically how I am doing all this. Is I am basically trying to give some message to the youngsters who is attending this webinar, that whenever you are plan for an AVM surgery, you should have a knowledge how one should proceed. That one should go for an elective or scheduled surgery, unless otherwise there is a big hematoma which is compromising the neurological status of the patient. That is the only case where you can go for an emergency surgery to save the life, to evacuate the hematoma. Otherwise, it is always should be done as the elective and scheduled procedure. You have to a team, discuss with the neuroanesthetist, physiologist, neuro nurse, and OT nurse, and the radiologist who will be there inside the theater, and always make your functionality, assess the functionality and ability of the equipments day before the surgery, whether the head fixator is intact, microscope is working, neuronavigation is there, different types of suction catheter there, bipolar country of different size, because the size varies with deep and superficial AVM. So you have to be at hand ready with these things, micro dissecting for forceps, and you have to have clips, different types. And this is the picture taken. Here you can see the different size of catheter, bipolar, dissector, and there are different size of microcism. So head position, if it is a surface and superficial, frontal, parietal, there is no need of any much of. Most important thing that the needles of these AVM should be topmost, and you should avoid flexion or rotate the head laterally significantly to avoid venous compression. And the size of the flap, it's always better to go for a large flap so that you can have a normal surrounding brain and identify the sulcus, different circumference, and eloquent areas. Before starting the resection, you have the neurophysiologist who can place the electrodes for your assessment of the cortical functions. The next is first step after the skin flap. Next is the bone flap. Always remember, when you are planning a bone flap, you take a big bone flap and use drill. And for bone cutting, remember, don't do one borehole, key borehole, and then start cutting all. Rather make multiple boreholes and join by cutting it, so that the dural injury is avoided, because you never know what is the status of the dura in the underlying bone. There may be very much adherence, so you have to have very cautious during this procedure, otherwise there will be a hematoma inside. Then flap must surpass the midline. It is always better to make a flap almost to the midline, so that you have a better anatomical picture and spot. And most important is you have to patiently and diligently separate the bone inner surface from the dura, which is very important. If you have asked your junior to do the craniotomy and suddenly he lifted it and there is tear, emissary or external carotid supplies, and there is massive blood extradurally or after the bone is open, then elevate the bone flap cautious to avoid dural or vessel or sinus tear, which normally happens during this stage. So you have to have very careful during this stage. If there is some sinus injury or vessel injury, you have to prepare by two suctions and Surgicel, Gelcom, all these things is basic requirement from the first step. Now coming to the dural opening. Dural opening with venous drainage towards the surface should be opened slowly and carefully to avoid torn in vessel. If by chance the venous drainage is torn, can lead to catastrophe. There will be sudden brain swelling and it will be difficult for you to handle the situation. So cut the dura and check the adhesion so that nothing is torn. Use of microscope during dural opening is of great help. Opening of dura mater must expose the interhemispheric fissure to have at a site where bigger area. Then coming to like some AVMs can present with big hematoma. In that case, you remove the hematoma, leaving a small part close to the needles. And keep the brain moist by continuous saline irrigation. And try to perform hemostasis with coagulation of large caliber venous vessels before excising AVM. It will be a very technical mistake. So always avoid coagulating large caliber venous vessels. But meeting that's it. Now coming to the AVM excision, I have shown a picture where you can see the arterialized veins indicating the site of nidus. Identify the arterial feeders, nidus, and arterialized draining veins. Find the ischemic lytic plane all around the nidus. Circumferentially dissection from apex to base or outside to inside fashion, because usually the AVM is a cone-shaped thing. I identify and meticulously coagulate the arterial feeders fast. For slight, moderate, large caliber, use clips. Once the feeders are coagulated, the color of the draining veins, you will notice that there is change from red to dark. Then small feeders are always present over the needles when you are doing. Then you will see there are small feeders over the needles close to the draining vein. So patiently dissect and coagulate this. Once assured of complete devascularization of needles, the draining vein is neither tied or clipped. Either tied or clipped. Finally, cut the needles close to the clipped veins and excise into it. This is a steps we have to mug it up before planning for any surgery. There are few cases I will demonstrate. This is a case of a young male presented with vertigo, headache, and focal seizure. 1 month duration. CT revealed some irregularly rounded, poorly marginated, heterogeneously enhancing lesions in the basifrontal area. And then on MRI, there is 24 into 21 mm size multiple flow wedge lesions. The impression of arteriovenous malformation, get an angiogram, and angio you can see there is a superficial AVM of size 2.5 centimeter, feeders from cortical branch from A2 segment of ACA, also filling to other side. Draining vein is superficial pre-Rolandic veins to anterior 1/3 SSS. So it comes around special grade 1. So we plan for surgery. And once we open the dura, this is the surface AVM which is seen. Unfortunately, I have not the video, lost it. But patient did well, and patient is on follow for the last 12, 13 years. There is no recurrence. This is another case of 35 years female presenting reeling head, seizure, vomiting, weakness, left side body. Got a CT scan done. There is a dumbbell hematoma. And in the CT angio, there is something fishy. There is a 2 centimeter size AVM. And on further CT angio, we confirm that there is a small AVM, but it is not very surface. It is subcortical. And the supply from the feeders are for M3rd segment terminal branches, draining veins into the superficial draining system. So we planned for surgery. I will just go for a video of this. Okay. Are you able to see my video? Hello?
No, so the video is not visible.
Okay. Let me share it. I think I have to share the video. Okay. Yeah, Akhil is there. Can you show the video?
Yes, sir. Video 1, correct?
Yeah, video 1. Can you show it?
Yes, sir.
This is the after craniotomy of the patient, and there is a big flap done, and the hematoma is almost seen there. Now Akhil will show the video.
Sir, you stop sharing. I'll share my screen.
Okay. How can I do that? I don't. I'll cancel this sharing.
Sir, at the top you can see stop sharing screen.
Okay, stop sharing. Okay.
Yeah.
Yeah, run it. Okay. This is the first I remove the hematoma. There's a huge hematoma towards and frontal area, pre-Rolandic area, and there is once the hematoma of that part is removed, you can on corticosectomy, you can see the AVM is seen. And the fundamental training is that you go all around that glyptic plane and it's, search for the feeders, and you see the small feeders, and as well as the posterior part of the hematoma is also being sucked out, and the feeders are seen, and the very small feeders because it's all terminal branches of the M4 segment, the MCA. Few are very moderate AVMs, moderate size vessels. All where feeders have been separated, coagulated, and cut. So that's the basic steps, is that you have to remember how to go for it. And many things are there. If you don't take the steps properly, you may yourself land in problem. There may be sudden bleeding, there may be sudden brain swelling, which will be out of your hand. Even if it is small, it can. I mean, it is a very small size feeders. They can use the hemoclips also. Here I have used hemoclips. So then you coagulate. Sometimes these clips doesn't occlude the vessels completely. They open up. So you have to coagulate as well as put the clips. Now, as I have mentioned many a times, the feeders you have to search very meticulously and dissect it, and then coagulate it, disconnect it. And once you are confident that you have done, now I am lifting the needles and seeing the inferior part of the needles with the glyptic plane and see is there any. You see there are still few feeders are there close to the venous running vein. The big size running vein is seen, and there is some feeders are still there. This is the time where you should not be very hurry, and you should patiently. I mean, this vascular surgery, if you are interested in vascular surgery, you have to, first thing you have to learn is to have patience, and you have to assist multiple times, and you have to have a homework before the day of surgery, and you have to take all into account, all your staffs as a team, to get the success. And now here, some people ligate it, and some people also use clips before lifting the exercise. Here I am using the 10 silk. I also use, because once I have tied it all automatically lifted up, so I use the hemoclip again after coagulation. And so once I'm sure that there is no further bleeding, I coagulated this cut edge. Here is the important thing. Now I am showing that it all done, but as a youngster, you have to have a lot of patience. Okay, Akhila, this is the end of this year. Then how can I? You saw the another video. Akhil,
Yes, sir.
the other video. The another case I also, there is a case of cerebellar EVM right side. There are now things have become much easier, which was not there 1 to 2 decades ago.
Can I play the second video, sir?
Yeah, I wanted it. Now you have intraoperative ICG, and you can go for your operative theater is so much that you can go immediately for a angiogram also. So that gives you, and neuronavigation is there. This is, you see, this is another intracranial AVM is running.
Pleasure.
Yeah, you play. Now this is the picture, and this is the angiogram. The supply is from the ICA, and it is basically transverse sinus. And you see, sometimes you miss because of large caliber of the venous system, you miss where is the feeder, where is the needles. In that case, nowadays it is helpful to do ICG, intra ICG, and get a clear picture. What actually, where is the AVM? That will help you. And then now you can see the AVM, and it's all looks like artery, which is vein, which is artery. It is difficult to know at times. So you have to be very meticulous and patiently you have to go through the climatic plane all around. And you should not do it one-sided. That will also cause a lot of venous pressure, and then suddenly it appears that it is going down, but suddenly there is enlargement of the AVM because of the pressure. So you have to go all around circumferential fashion, and once you are done, then you tie the thing and you lift the needles, and your surgery is over. Now you can close that video. I will share my slides. How can I share now?
The same way, sir. Beginning how you shared in the
It's
same way.
it's there. Are you able to see now?
No, no, sir.
No, not yet, sir.
Okay. Share. Able to see? Hello?
Yes, sir.
So we are
Visible.
able to see. Please proceed, sir.
Yeah. So these are the two videos I have shown, and this is the picture of the first case, post of angio. And second case, I have shown the ICG is better to know where you have done and what you have left. Now, next is closure. The basic steps of AVM, the most important is closure. Normally, what we as surgeon, we just leave it to the residents and have pop-up smokes or lunch, but that we should not do in particularly case of AVM. Patiently wait and watch for any fresh oozing indicating residual fetus, brain status, whether pulsatile or any tense brain indicating vascular compromise. No need of watertight dural closure if you are not able to use rather GPAS to expand it. Decide whether to keep the bone flap back or preserve it on spot. Always put a drain, though on mild negative pressure. ICU, yes. Don't extubate immediately. Rather keep an elective ventilation unless you confirm intra ICG or on post-op scan. No fresh bleeding, no brain swelling or pressure effect. And angiographical sure of complete occlusion of feeders and no residual AVM. So these steps are very important from starting from the skin margin to closure. Each step is very important if you want to be vascular surgeon, particularly arteriovenous malformation. Now, a few words, as already Dr. Daljit mentioned, normal pressure breakthrough bleeding. This is for no, and I have shown it pictorially. Now, this is the AVM. There is a normal vessels. If there is a AVM, these vessels get dilated and they lose the auto regulations. And once you clip this AVM and cut it, then suddenly there is gush of blood, and this blood and this vessels, as it lost auto-regulation and the wall is dilated, there is seepage of blood, and this seepage of blood make a intra-bed or post-op bed lot of blood and brain swelling. So it is usually seen in high-grade AVM. High-grade means it's not only size, maybe because of the arterial venous and system and location. All this take into account. Normally, it can happen in a grade 1, grade 2 also. If it is a large size AVM, 6 centimeter, and there is grade 1, grade 2, that can also lead to breakthrough and is a long duration AVM. So caused by diversion blood flow from AVM into adjacent, maximally dilated, non-auto-regulating small vessels leading to seepage of blood from vessels to operative bed. The basic treatment is to keep the blood pressure slightly low, hypertension in the method, or without compromising perfusion pressure, it has to be kept between 50 to 70, otherwise there will be more ischemia, hypovolemia, and hyperventilation. Steroids should be given, and you can go for barbiturate coma for 24 hours. That is the treatment of breakthrough bleeding. So to conclude, intracranial AVM surgery needs meticulous planning and multidisciplinary approach. Always do it as an elective or scheduled surgery. Surgical teams should be well prepared for any untoward event. Each step is important and to be remembered and conceptualized before. Meticulous execution of steps result in excellent surgical outcome in a selective grade intracranial AVMs. I have not mentioned a lot of things like deep AVMs, the most important surgically when you go towards the end, periventricular area. So you have to be very careful. We will discuss in the next talk. Thank you very much.
Thank you, Dr. Pradipta, for a beautiful explanation of a very complex surgery. I now request my co-panelists, Dr. Sandeep and Dr. Anil Tripathy, for any comments and questions. Dr. Sandeep?
Hello.
Yeah.
Hello.
Yes, Dr. Sandeep, please.
Audible.
Yes,
Yeah,
sir,
yeah.
you're
Audible.
audible. Yes.
Very nice presentation, Dr. Tripathi. Tripta. The only point which I would like to highlight in the surgical excision of an AVM is to keep the bipolar, especially for the youngsters, if once they start with this kind of surgery, to keep the bipolar at low intensity and keep the operative field
absolutely.
Fully loaded with saline, plenty of saline, 2 bipolar forceps at hands, and the nursing staff should be quite experienced one to exchange the bipolar forceps at a frequent intervals. That is the most important thing. And coagulating these feeding vessels, like those are all abnormal vessels which are feeding the AVMs.
Yeah.
So those vessels should be coagulated at a very low intensity, but for a prolonged duration, and then cut with microcisors under microscope. But that's the only point which I would like to highlight.
Yeah.
Very nice presentation, Dr. Pradipta.
Yeah, I mean,
Thank
even non-touch AVM bipolars are coming where the tip only send the currents. Otherwise, the
Yes.
rest part that is also good. And you, as you mentioned, it has to be irrigated continuously, and the intensity has to be modulated. And one person has to be there to modulate this bipolar
Yes.
10,
Yes.
20, 20, 5, 6, 10. That is very important. Yeah.
Yes. Thank you. Thank you, sir.
Thank you. Dr. Alan Tripathi, any comments and questions?
Hi, Pradipta. Very
Yes, sir.
nice cases. Can you stop sharing? Then we can see.
Yeah. I will stop here. Okay.
It was very nice to see your work.
Yeah.
And I really appreciate
Sure.
your ABM work. And like Sandeep just mentioned, I think, identifying the feeding arteries and protecting the vein till the end. I think the main feeders still, with a good bipolar and irrigation technique, you can get around. The pile feeders are really the bothering. Small pile feeders are the bothering things, and they are the ones who can be left behind at times. And the main feeders, usually we take it and exercise the AVM. Of course, the capacity of doing surgery in these difficult AVMs is very, I think, personal. And one has to take all the factors that Daljit mentioned before you spoke, very individualized, the decision making, making sure that you get the patient better than worse.
Yeah.
And we know our complications as well. It is possible, and that is the philosophy of preventing any complications. Especially AVM is a very, very dangerous situation. If you don't know how to do AVM, like you mentioned, better do it with a lot of patience, and you need the patience till the end.
Yeah.
And after.
Absolutely.
And after.
Yes. Even after.
Even after.
We should not extubate. At that point, I like.
Yeah, I mean, you never know what call will be in the night.
That's right. Yeah, thank you very much.
All your
Thank
efforts has gone wrong and patient is no more. So
nice cases.
better.
Thank you, Pradipta.
Yeah, thank you, sir.
So I just wanted to ask one question that all the panelists said whether the surgery for an eloquent cortex AVM would be any different from the surgery for a non-eloquent cortex AVM?
I mean, it is not, if it is a surface AVM and eloquent area AVM, of course, the only thing is neurological deficit. So you have to have a neurophysiological study during the procedure. That is the one thing I feel is essential. Or you do a functional MRI before and note out the area where you have to be very cautious. That is.
And also, I just want to,
Yes,
if I can
Dr.
add one point,
Yes, please.
is that, very few people in the world do AVM surgery awake. And
Yeah, I
we've
mean,
seen,
Dr. Sala is used to do this. I don't know, he
Salim.
used the aneurysm, but AVM, I don't
Yeah.
know.
So eloquent protection, of course, very, very important. And many surgeons will not operate on really eloquent cortex, especially somebody is a singer and, his job is to speak and, in the Broca's area AVM. And if they have to do it, medical students, and, we all need our speaking capability
Yeah,
anyway, but
absolutely.
that is very, very essential to distinguish. But yes, awake surgery, and if you can do, especially the unruptured AVMs presenting with seizures and steel and what have you, is a possibility, but it's not easy. You have to have the team to do awake AVM surgery. And I've visited Salim's theater, and I
Yeah.
know how he manages, but not many people do AVM awake.
Yeah, Dr. Deepak Khatri has asked a question. What's your opinion about DTI for eloquent region AVM?
Eloquent
Absolutely, we use DTI, functional MRI, to know the tracks, fibers. These are all essential anatomically to go for eloquent India AVM.
Do you think, sir, that pre-op embolization of an eloquent cortex or near eloquent cortex AVM helps you in surgery because it actually gives you a tumorish feeling when you're resecting it? In a non-eloquent cortex, perhaps you have
that
that
is there.
difficulty that you might just 0.5 millimeter or centimeter, you might just take out even the non-eloquent cortex. But in eloquent cortex, you have to be very close to the AVM. So pre-op embolization, do you think it really helps in surgery in a near eloquent cortex or eloquent cortex AVM? A pre-op
It all
embolization.
depends upon which grade you are planning for surgery. If it is grade 1 and grade 2 and the surface superficial, I don't think any need of embolization also. You can work out without causing any neurological deficit if you are anatomically or functionally you are assessing intraoperatively that you are handling not the areas which are functional capacity. Otherwise, if it's a grade 3A or B, yes, embolization will definitely cause any compromise of the vessels, and it is not advisable for. Mohindra will say, 3A, B in a eloquent area, I will not go for any surgery. Eloquent area, unless
Agreed.
otherwise patient is in a very bad condition.
Agreed. I fully endorse your views. We are not using embolization nowadays in PJ Chandigarh. We are splitting the cases into two territories. Like one is surgical excision and the other one is radiosurgery. Come on.
Absolutely.
That is the absolute. If the AVM is located at a very eloquent area and is a poor grade, right, higher grade of Spitzer Martin, the patients will be subjected to radiosurgery directly.
Absolutely. Yeah.
No experimentation with embolization and then followed by surgery. It's not being done these days.
Yeah.
Thank you.
Okay, Dr. Mehrotra, if you permit me, I have to say thank you to all of you as a panelist. I have to leave also personally.
I think this is the last.
I'll stay back. I'll stay back.
So thank you all the speakers and my co-panelists for taking out your precious time and being a part of this webinar. So thank you very much. And on your behalf, I would like to thank the CVSI for giving us this opportunity. So thank you very much. Thank you.
Thank you.
Can I leave now? And
Thank you. Bye,
I thank
Sandeep.
you.
Bye, Pradipta.
There is another talk is there. Chaturvedi is there.
No, so actually he had some family commitments, so he had to leave. So he shall not be giving his talk.
So he's not giving his talk. Well, then
that is why we only had two talks, yours and Daljit Singh's talk.
Okay, that's fine. The audience is very less, but it is very important talk. So next we'll grow by second topics like AV fistulas and all great
Yes.
three, and lastly we'll go for radio surgery. So thank you very much, Mohindra and Mehrotra sir, for being there. And though they are lost very less participant, but they are very active. They here still there is some question is there. I don't know what he has asked. There is a last question is.
Yes.
Thank you, everyone.
Yes,
Okay.
thank you. Visitor, thank
Okay,
you.
sir.
Thank
Good
you.
night. Good night. Thank you.
Good night.
Okay.
Thank you.
Bye-bye.
Akhila, can you just end the webinar? Akhila.
Yes, sir.
We are done. So
Okay.
okay. Thank you all. Good night.
Okay.
Right.